Hello, everyone. My name is Amari True McKay,
I'm Laura Sadi.
And I'm Emily Carrier.
and today we'll be talking about healthcare accessibility and maternal mortality rates, policy suggestions from California.
So the issue we're addressing here is that the US is the developed country with the highest maternal mortality rate. The US's maternal mortality rate is currently 17.1 per 100,000 live births, compared to other developed countries which have rates ranging from 1.1 to 8.7 per 100,000 live births. This reflects a rate increase by 42.9% over the past 20 years, compounded by racial inequality.
So California offers us a useful case study here because it is racially and ethnically diverse and responsible for 1 in 8 US births annually, which gives us sample sizes that are readily available to apply to the other minority populations across the US. California actually has the lowest rates of maternal mortality in the US. However, we still see Black women being the main population affected by these deaths, which is representative of the rates in the rest of the US. On the left graph here, we see that even in California, Black women's maternal mortality rates are nearly 4 times higher than white women's. And on the right graph, we see that California's maternal mortality rate has mostly decreased since 2008, while the US's rates have increased. So California's preventative measures have clearly done well to keep maternal mortality rates low. So we want to study and suggest this to other states going forward.
So for our objective, we're trying to highlight risk factors pertaining to cost and accessibility of healthcare because minority communities suffer the most health disparities. Our study's population of interest includes Black and undocumented women of the reproductive age, which have the least interactions with the healthcare system. Additionally, groups that will be directly affected are mothers who deal with medical complications and trauma, underserved families who bear the burden of the responsibility of child rearing following these deaths. Indirectly, this affects public health educators, free clinic and doulas or midwives who provide preventative services within the public health workforce. Further, in between direct and indirectly affected, adoptive social workers are involved in the process of placing displaced children into the foster system if a family is unable to step in.
According to the literature, these articles provide a comprehensive overview of our policy recommendation. This includes successful intervention programs to combat unconscious racial bias and would be centered around bias reduction strategies. The importance of healthcare providers' cultural competency is vital to reducing the gap in disparities and understanding underserved populations.
Our second study here found that 60% of maternal deaths are preventable through insurance rate increases. So this can be achieved by Medicaid extension to 1 year postpartum and Medicaid expansion to include more vulnerable populations, including undocumented immigrants.
For our last literature evidence, research highlights that the adoption of Medicaid expansion is associated with lower maternal mortality. This would contribute to decreasing racial disparities, and we know that undocumented immigrants are not able to participate in Medicaid using federal funds, except emergency Medicaid, which is state funded. With Medicaid expansion, undocumented women, which account for 2.5 million people, will have higher access to healthcare without regard to their immigration status.
Our outcomes include Medicaid expansion and extension, as well as implicit bias training for healthcare workers, which we will believe to have a substantial effect on maternal mortality rates among Black women. In comparison to our base study, Medicaid expansion would provide a 48% increase in insurance rates. However, the most cost-effective options are Medicaid extensions with 12% increase and implicit bias training with 5% increase in federal spending. Further, among Black women, the rates would decrease by 61% with implicit bias trainings. It is important to point out the statistical estimates for the value of a human life is $7 million. According to our rough calculations, if we look at the overall maternal mortality, rates would decrease by half with Medicaid expansion, and implicit bias trainings would end up saving around $1,409 million in human lives.
So for our fiscal policy cross effect, there's going to need to be about a 12% increase in federal funding to implement these reform measures. However, this money can be found in the federal budget for child help programs, which include child protective services and the foster care system, which children can be forced into after a maternal death. For immigration policy cross effect, we know that under the current Medicaid, undocumented people only have access to emergency services. So this includes birth, but does not include any prenatal or postnatal care. We also know that healthcare accessibility is culturally affected as this population can be scared to access services for fear of retaliation on their immigration status. Further, because our fiscal policy can be justified through the reduction of child help programming, this would be a fiscal transition from retroactive help to preventative measures. Ultimately, reforming Medicaid decreases the number of uninsured, leading to increased accessibility and accomplishes our goal of decreasing maternal mortality rates. So the ultimate measure of success here would be an increase in insured mothers and a decrease in the overall maternal mortality rates of the U.S.
Based on current flexibility in the Medicaid program, there is considerable variation in per enrollee costs across eligibility groups and across states. Evidence shows that the federal government is responsible for around 64% and state funds the remaining 36%. As reflected in the graph, enrollment in Medicaid grows during economic downturns, increasing state Medicaid costs at the same time that the state tax revenues decrease. Thus, there are peaks in Medicaid spending and enrollment during recessions and recently, as we saw in the COVID-19 pandemic. From a fiscal policy perspective, California serves as an equitable model because it is seeking state funding to expedite Medicaid reform. However, even with a given state and eligibility group, per enrollee costs may vary significantly, particularly for individuals that encounter disparities. Additionally, we're exploring immigration policy effects on health policy. Undocumented immigrants are the least likely population to seek emergency health care because of fear of deportation. Of the 11 million undocumented immigrants excluded from Medicaid, 2.5 million are women of the reproductive age. This concludes that immigration policy limits the accessibility to health resources for the undocumented. Currently, California has developed Medi-Cal health coverage options for undocumented immigrants through state funding.
This brings us to our recommendations and conclusions. Extending Medicaid for pregnant women to 1 year will help reduce maternal mortality because this high-risk time will be covered for postnatal care. Further, the expansion of Medicaid to include undocumented population will help them with pre- and postnatal care regardless of their immigration status. Finally, implicit bias trainings for maternal health care professionals will create culturally sensitive spaces for mothers to allow for a better diagnosis while also rebuilding trust within marginalized communities. Thank you so much for listening, and we'll take questions during the panel session.